and shared on our COVID-19 webpage. So Brian, if you want to start recording, you can do so now.
Awesome. Thank you, Emily. We're going to go ahead and go into some staff introductions. My name is Lauren Burns. I'm a project program coordinator at USET. Brian, if you already introduced yourself, Emily did. Christy and the EPI team, if you want to go ahead and introduce yourself.
Sure. My name is Christy Duke, and I'm the senior epidemiologist here at USET. I've been with USET for almost 18 years now, although I have to say this situation is brand new for me, as I know it is for everybody else. I'm happy that this is going to be the first of a series of echo sessions that we are going to conduct around COVID-19. And I'll turn it over to Dr. Brown right quick.
Yeah, good morning, everybody. Harry Brown. I'm part-time medical epidemiologist for USET. I've been with them since last fall. Did not anticipate working quite as much and quite as hard as I have been for the past month, but it's been very interesting.
Okay. Hi, everyone. This is Tori Reeves. I am staff epidemiologist with USET. I've been with USET, it'll be 5 years next month. And that's it. Thank you.
Hello, everyone. My name is Imani Ransby. I am also a staff epidemiologist with USET. I'm relatively new, but I'm happy to be here.
Thank you. And Dr. Mira, if you'd like to introduce yourself.
Yes, I'm Jorge Mira, Cherokee Nation Infectious Diseases, and very delighted to be here today. Thank you for the invitation.
Awesome. Thank you so much. So we are going to go ahead and move to the USET staff surveillance. I'm going to share my screen with their presentation, and I will have the USET EPI team take it from there. Just a moment. All right.
Thank you, Lauren. This is Christy speaking again. Let me just go over the general talking points that we're going to cover today. I'm going to talk just briefly about what's going on in the Nashville area in terms of COVID-19 epidemiology. And Dr. Brown will talk about the new Abbott ID NOW test that has come out. I believe all tribes that are going to receive the machine have done so, have received it. And he's going to talk a little bit about how this particular test may affect public health intervention. Tori and Imani are going to talk about contact tracing and the surveillance tool that the USET Tribal Epidemiology Center has created for your use. And then we'll go into questions, and then I believe we'll pass it off to Dr. Mira. So with that said, just briefly, we've been collecting data from 15 sites that we and the area office, we've been working together and updating these numbers daily to see what is going on in terms of testing and positives. And as of this morning, there have been 569 tests performed. I am not entirely sure if those are the Abbott tests. My guess is it is not. I believe the first site is ready to start rolling that out either today or maybe Monday. So I do expect this number in the next week or so to go up as the Abbott tests come online. Only 26 positives that we've had in our area, but again, we do know that there has been a lack of testing up until this point in time. 401 negative tests and 145 in process. Some tribes have chosen to use a case definition and a presumptive positive diagnosis. And amongst the sites that are doing that, we've got 3 presumptive positives. As I mentioned before, I do imagine the number of tests is going to go up, and probably the number of positives in the next few weeks, as the tribes that have the Abbott machines come online and start increasing the numbers of people that they're currently testing. So with that information, I'm going to turn it over to Dr. Brown to just briefly talk about the Abbott test and what the benefits and limitations are regarding that test in terms of public health approaches. Dr. Brown?
Yes, thank you. So part of the challenge with this new disease has been testing. The only test that we've had is a PCR test that is taking, in most cases, days to come back because those have to be sent off to a reference lab. For example, I admitted a patient to Cherokee Indian Hospital last Saturday, and the test result on that patient just came back this morning. So, you know, it's taking a week or more to get the test back. So about 2 weeks ago, the FDA issued an emergency use authorization for the Abbott ID NOW instrument. This is actually an instrument that's been used for some time to test for respiratory syncytial virus, influenza, and group A strep. So the technology that it uses is not brand new. It is similar to PCR in that it looks for viral nucleic acid. PCR testing usually is looking for at least 3 different sequences of the viral nucleic acid. This test actually just looks for one small unique piece. It uses an isothermal process that makes it much, much faster. Regular PCR requires several different temperature cycles, whereas this machine is able to do it with just one temperature cycle, and results come out. You can get a positive test within 5 minutes. Negative tests take about 13 minutes to do. The Indian Health Service purchased 250 of these machines for distribution around the country. Nashville area, I believe, has received 14 of the machines, and those have now been distributed. I know yesterday at Cherokee Indian Hospital, I got a look at the machine. It's quite small, and it's supposed to be put into use there today. They were doing the calibration and testing yesterday. Part of the problem, though, is that currently the test cartridges are quite limited. I know that Cherokee only received 48 cartridges and had to use a number of those for calibration. So until more of the cartridges become available, this test is going to be fairly limited. One of the really big limitations of the test is that we really don't know the sensitivity and specificity right now. So it probably has a pretty high specificity. In other words, if you get a positive test, that probably is reliably positive. However, we just don't know the sensitivity. So at this point, it really cannot be recommended for mass screening, because of course, for mass screening of a population, you would want a test with high sensitivity. And until we know more about the sensitivity, it's just not recommended. So the big advantage is the speed at which you will get the test. Next slide. This picture here is a picture of Amanda Peterson. She's one of the really great lab techs at Cherokee Indian Hospital. And you can see how small the actual instrument is. That's Amanda standing next to the instrument. So I want to switch gears here just a little bit and talk about, the fight that we're currently engaged in with SARS-CoV-2. So what weapons do we have to fight this virus? Well, currently there's no proven therapy. We can only do supportive care. Currently there's no vaccine. So the only real weapons that we have involve 19th century type public health technology or weapons. We can do case finding, contact tracing, and isolation of the cases and quarantine of their contacts. So at this point, the best offense that we have is a good defense. So with that, I'd like to turn it over to my colleagues, Tori and Imani, who are going to talk about these things.
Thank you, Dr. Brown. So as Dr. Brown mentioned, contact tracing, it is a public health method that is often used in outbreaks, pandemics, epidemics. It is a really good public health method to identify cases, infectious disease sources, and to also serve as a method to stop or decrease the amount of transmission. There are 3 basic steps for contact tracing, and it begins by identifying a possible or suspected case. For here, we're talking about COVID-19. So once you have the identified case, you can begin to reach out to them and just kind of determine some simple information. And next slide, please. So the basic steps of contact tracing is contact identification is once you identify that confirmed case. Second step, contact listing, and third step will be follow-up. So with contact identification, you reach out to that confirmed case. You want to know what their activities are, any movements they've done, the orange symptoms, and when did their symptoms start? If they don't know, just kind of like estimate that with like 2 days. Symptoms typically, you become infectious 2 days after symptoms start. So we want to know any contact that they've had with anyone for 10 minutes or longer or within 6 feet from them. Information that you need to collect would be name, address, telephone number, and email address if possible, because that is something essential in our time. You want to have this information to make sure that you can reach out to the suspected contact and just kind of like let them know they've been identified as having contact with a person that has been confirmed with COVID-19. They should be provided information on prevention and control measures, including isolation and quarantine if that needs to happen. Also ask about their symptoms. If they've developed symptoms, make sure to inform them of all the symptoms that may develop with COVID-19. Advise them for daily temperature checks to make sure that they keep note of those and how to proceed if they start to develop symptoms. Each area does have their own recommendations on how to proceed for early care if you do suspect that you have COVID-19 and you're developing symptoms. So they should be directed towards those local guidelines and recommendations. And the last step for contact follow-up, it should happen throughout the process. For COVID-19, that follow-up should extend 14 days from their exposure to the COVID-19 case. And again, throughout this time, you should be reaching out to them, make sure you're asking about symptoms, their daily temperatures, as well as they're following the guidelines for isolation or quarantine, or if they've had additional contact with people if they're not following those guidelines, if they've left out, and if they've possibly exposed any additional people to COVID-19. So this next slide. Here's a picture of just talking about what contact tracing does, how it allows sick individuals to be identified and then their contacts, and this is to find cases and isolate contacts to decrease the spread of COVID-19, and the difference between contact tracing and community monitoring. Both of them are really great public health methods to use in outbreak or pandemic situations. Next slide, please. I'll go ahead and hand it over to my colleague, Imani.
Thank you, Tori. So I will now provide a brief overview of the USET TEC COVID-19 surveillance tool. The surveillance tool was created as a result of the COVID-19 pandemic and its current impact on the United States and tribal nations, as we have now become the epicenter of the outbreak. The main purpose of this tool is to document and track suspected and laboratory confirmed COVID-19 cases so that tribal nations can evaluate the impact of the outbreak and then use that information to decrease the spread of disease. The surveillance tool itself takes on a form or questionnaire style approach to capture specific information about patients who are suspected of having COVID-19 or who have had lab confirmation of COVID-19. The questions that are contained in the surveillance tool can be modified and or omitted so that the tool can be tailored to meet the needs of your tribal nation. So please keep that in mind. The surveillance tool also has been formulated to have contact tracing capabilities, which Tori just shared with us. And then it also assists with patient follow-up. So if a patient was seen and had a pending test result for COVID-19, once the result is obtained, you can go into REDCap via a valid REDCap account and then update that information accordingly. The USET TEC is advocating for the use of both RPMS and the USET TEC COVID-19 surveillance tool. Although RPMS now has the appropriate functionality to track COVID-19 cases, it is still limited in that there's a significant delay in getting any labs back, and RPMS will not reflect COVID-19 diagnoses until the lab is back in the system. So in sum, we are advocating for the use of both so that you can appropriately track COVID-19 suspected and confirmed cases and then use that information obtained to implement public health practices and decrease the spread of the virus. The surveillance tool is housed in a database system called REDCap. It is secure and HIPAA compliant. Each tribal nation will have access to their own surveillance tool and the data that is contained in that tool. Only designated staff at your tribal nation and select USET TEC staff, including myself, Tori Reeves, the other staff epidemiologist, and Taloa Berg will be able to view the tool and the data that's contained in it. If we could go to the next slide, please. Thank you. Oh, you're already there. So the surveillance tool features the following fields with questions listed underneath. You have patient demographics, COVID-19 exposure history, comorbidities and smoking history, signs and symptoms, and then an area for COVID-19 testing. If we can click the surveillance tool demo link, that will take us to the live surveillance tool questionnaire. And if that does not work, I also have a screenshot. Okay, great. Yes, technology is on our side today.
Yeah.
So just to provide a brief demo, as you can see, if we just scroll through, there's the patient demographics area where you can enter information such as sex and race. If you continue to scroll, COVID-19 exposure history, you can indicate who the patient has been exposed to, whether that's a person under investigation or a lab confirmed COVID-19 case. The comorbidities and smoking, which are essentially risk factors for COVID-19. Signs and symptoms, we've included cough, fever, and shortness of breath. And then COVID-19 testing, which includes details regarding testing, pending positive, negative test results, and testing facility information. I do want to make note that that last question field that states, please list the REDCap record ID number if the patient has a known lab confirmed case contact, can be used for contact tracing and linking. So yes, that pretty much sums up that part. You do not need a REDCap account in order to fill this form out. So please keep that in mind. If you do have access to a REDCap account, you would be able to view the current questions that are contained in the surveillance tool. And then if you would like to submit changes, you can definitely do so. As I mentioned before, you can run reports and get a breakdown of responses for each question or field in graph form. You can also view how many forms have been submitted and then export data into various formats. I think they have CSV, SAS, SPSS files in which you can export the data from your surveillance tool. Once that form that we just looked at is submitted, it will be documented and logged into REDCap, and you can easily view that via a valid REDCap account. Please note that that questionnaire does take about 5 to 10 minutes to complete. And again, if you would like to modify or omit questions that are already included in the surveillance tool, then please send requests. You can send those requests to Tori Reeves, the other staff epidemiologist, or myself. And then next slide, please. So I just want to close by saying if you would like to request a REDCap account and get access to the USET TC COVID-19 surveillance tool, please contact us at usetepi@usetinc.org. And I think we can take any questions now if.
Thank you, EPI team. We are going to hold off on questions until the end after Dr. Jorge's presentation, if that's okay with y'all. With that being said, Dr. Jorge, you have the floor. Do you have your presentation? Okay.
Sorry, can I just?
Yeah.
One correction. This is Tori, the staff epidemiologist. I just want to make the correction that when I said symptoms, contacts or case becomes infectious, I said 2 days after. It's actually 2 days prior to the onset of symptoms. I just want to make that correction and make sure that I'm not giving out misinformation. So, thank you, Lauren.
Thank you. All right, and with that, Dr. Jorge, you have the floor.
Okay, can you see my slides?
Yes.
Oh, okay, thank you. Yeah. Okay, so I'm going to cover today an overview of COVID-19 and with the updates that I think are relevant that have occurred in the last few days. I'll skip the first 2 slides because this is just the Cherokee Nation Health Services COVID response. I'll share the slides with you, but I don't think we have, I need to go over them because it's just a inner process. So I will be covering a little bit of virology, epidemiology, clinical manifestations, infection control, and what we know of treatment so far. So first, a few things about terminology. So coronaviruses are RNA viruses with spike-like surface proteins, and that's what under electron microscopy gives it the shape of a crown. Then it's called corona. It was not named after the beer. Just want to clarify that point. And SARS-CoV, it's the acronym for Severe Acute Respiratory Syndrome Coronavirus. It was first described in the 2003 China outbreak. And SARS-CoV-2 is the Severe Acute Respiratory Syndrome Coronavirus that causes the present epidemic. The disease is called COVID-19 because it's the coronavirus from SARS-CoV-2 that was discovered in 2019. So there are human origin coronaviruses and animal origin coronaviruses. We have 4 known human, and I'll show a slide of the activity they have in our communities, at least here in Oklahoma. And then we have animal origins that have jumped into man. So basically, it is thought that from a bat can go directly to a human, or from a bat can infect animals, the pangolin here, and humans can get infected through exposure to those animals. And in China, we had the SARS-CoV in 2003, and the MERS coronavirus in 2012 in the Arabian Peninsula, and the SARS-CoV-2 2019, which started in China last year. So one of the questions we get a lot is this virus seasonal? So we don't know about COVID-19 if it's seasonal or not, because it hasn't been for a full 4 seasons yet for us to know that. But here I put in this graph, coronaviruses diagnosed at Cherokee Nation Health Services And we do film array PCR on all patients who get admitted to the hospital for respiratory infections, and also on healthcare workers with respiratory infections. And as you can see in this graph, all the other four are very seasonal in our population, at least. You can see that from November to March, there's spikes of all these coronaviruses, and the different colors are just the different types of coronaviruses. So let's hope and cross our fingers that maybe this one has some seasonality and it starts fading away in the summer, but we don't know that yet. Transmission, we know it is transmitted by droplets. We also know if someone coughs or sneezes on a surface and someone else touches that surface and takes their hand to their mouth, nose, or eyes, they can auto-inoculate the virus. And so fomites are a way of disseminating it. But what we are not sure if it's airborne, and that's important to clarify because CDC has given recommendations to use airborne precautions, which I think is a conservative measure and fine. But as far as we know, it's basically a droplet transmission, but there are procedures in which aerosols are generated, especially in the hospital, like when you're nebulizing someone or intubating someone, or during suctioning of the trachea. So all those procedures can generate aerosols, and it could be potentially airborne in those situations. The risk of transmission, in studies done in the United States, one individual will transmit it to less than 1% of their close contacts, and defining close contacts as someone who's 6 feet away from you without any PPE, and you spend at least 10 minutes of your time within those 6 feet. The incubation period is pretty consistent in the studies done in China and the US, about 5 days, but it ranges from 2 to 14. And the majority of the people who present with symptoms will have them by day 11, 11 and a half days. Now, 1% of the individuals will present with symptoms 14 days after the exposure, but CDC decided and WHO to use 14 days as our quarantine because it covers 99% of those who develop symptoms. Now, having said that, we all know, and I'll show a couple of slides, is there's a lot of asymptomatic transmission going on, and that's one of the reasons that this virus is so transmissible. So many of you heard the R-naught concept, and that's the basic reproduction number, and that's the number of cases generated by a single infectious case in a population that does not have immunity to that infectious agent. So the R-naught for COVID-19 is between 2.2 and 3.5, depending on which study you read and phases of the epidemic or the pandemic, which means that one person will end up infecting 2.8 other individuals. These are the R-naughts for other diseases. Just to put it in context, measles, which is an airborne disease, very transmissible, has an R-naught of 15. One measles case infects 15 other people. So why is this spreading so much faster than the SARS virus in 2003, which is actually contained? Since survival in surfaces is similar to SARS, retention in aerosols is similar to SARS, but what this virus is probably different is that there's a very high viral loads when the persons are getting symptomatic. And the most important thing is that unlike the SARS virus in 2003, there's asymptomatic transmission has been documented. And that's probably why it's spreading so fast. So this is just an example of a cluster in Singapore. Asymptomatic transmission has been reported in 6.4% of the patients in Singapore and 12.6% in China. And this is just one of the clusters that I'm showing you in this graph. And as you can see, patient A and 1 are the source patients. And on day 19 of January, they came into contact with patients A3, 4, and 5. But patients A1 and 2 were asymptomatic during this period. And the blue squares, the dark blue squares, show when each patient became symptomatic. And you can see there that patient A1 and A2 became symptomatic on the January 22 and 24th, and their contacts, A3, 4, and 5, became symptomatic many days later. The transmission was asymptomatic. And also this has been documented in several areas, including the United States, in which a nursing home, a skilled nursing facility, in which a healthcare worker was positive for COVID-19. They tested 76 out of 82 residents, and 30% had positive test results for COVID, of which half of them were asymptomatic or pre-symptomatic on the day of testing. So, symptom-based screening in nursing facilities in this paper may fail to identify infection. So this is a problem that we're dealing with. Looking at the China data, age distribution and case fatality rates, most of the Chinese patients, 30 to 60 years old, 77% of them became with mild symptoms, meaning did not require hospital admission, and 19% did require hospitalization, and about 5% critical care. Overall, the mortality in this 44,000 group was less than 1%. But if you start stratifying by age, you can see that the older the people get, the higher the mortality, being 14.8% if you're over 80 years old. And also, if you have comorbidities, your mortality goes up, depending on which one you have, 10% for cardiovascular, 7% for diabetes, etc. But these diseases have synergistic activity on your mortality when they add up. For individuals who end up in the ICU who are severely ill, the mortality rate was around 49%. Now, this is data from the United States of the first 122,000 cases of coronavirus and reported to the CDC. I just want to mention that on this MMWR report, only 7,000 patients had complete clinical data to show the data that is below this first line here. So this is based on 5.8% of the patients. So overall, 37% of the patients in the US has an underlying disease. The most predominant one is diabetes, 10%, COPD 9%, and cardiovascular 9%. But when you look at patients that are hospitalized, 78% of the ICU patients and 71% of the non-ICU patients had underlying conditions, compared to 27% of patients who were not hospitalized. And when you look at patients who died, 94% had an underlying condition. So the bottom line is being older and having underlying conditions increases your risk of mortality. And one variable that I did not add here, which was reported in a study, not published study yet, is smoking. Apparently smoking independently increases your odds ratios by 2 of developing a severe disease. So this is, again, I'll skip this slide, or I'll mention it very briefly. This is the same previous study I showed in the previous slide, and pointing out that adults 65 years or older represented 31% of the cases, but they represented 45% of the hospitalizations, 53% of the ICU admissions, and 80% of the individuals who died. Okay, what is the clinical presentation? So fever is probably the most common symptom. It's present at, depending on which study you read, 75 to 90% of the patients at some point during their illness. But it's important, when they come to the hospital, only 50% have fever. So you cannot exclude this with the absence of fever. Then the next most common symptom is cough, and it's usually a dry cough 70% of the times. And finally, shortness of breath is the next frequent symptom. There are other symptoms like myalgia, upper respiratory symptoms and GI symptoms, but they occur less frequently. GI symptoms occur more in children than in adults, but they occur in both. And the triad of fever, cough, and shortness of breath is only present in 15% of the patients. So you have to be, your threshold for looking for this disease has to be extremely low. The only major abnormalities in the lab work is lymphopenia, present in 40% of the patients. It's interesting, I just want to mention the 4 or 5 patients that we had in the hospital, all of them had lymphopenia, and most of them had elevated LFTs. In radiology, the typical findings are ground glass opacities and bilateral infiltrates that occur on over 70% of the patients. Very interesting. So this came out in a very recent study published in JAMA a few days ago. And they looked at co-infections with other viruses. And the bottom line is that 9.5% of the individuals who in this study had COVID had another virus detected in the nasopharyngeal swab. And the most common viruses were rhinoviruses, RSV, and other coronaviruses that are not COVID-19. So they concluded that there's a higher rate of co-infections between COVID-2 or COVID-19 and other respiratory pathogens, that the presence of another pathogen does not exclude COVID. This is very interesting because at the beginning of the pandemic, if someone had the flu, we wouldn't test them for COVID. And after a week or two, we started testing everybody that we could. But this study proves that that should not be the case. And also, one thing that I kind of disagree with the authors is that they say routine testing for other non-SARS, not other viruses beyond COVID-19 during the epidemic is unlikely to provide clinical benefit unless a positive result would change disease management. So I do agree with this last statement. So if a patient has influenza, you would treat influenza. But also in hospitalized patients that we know they have a virus and they don't have COVID, it decreases the antibiotic use and treating those pneumonias as bacterial pneumonias versus not. So who to test for COVID? Well, you know, it basically depends on your availability of tests. Ideally, you should, if you have enough tests, you should test anybody who presents with a fever or cough or shortness of breath. And in some situations, you know, even a sore throat would merit testing. And the reason that we don't test more is just because we don't have enough tests available. But if you have to restrict testing because of capacity, and we had to go through this problem, the first people that you definitely want to test is people you're hospitalizing and healthcare workers. And if you have more tests, you can add symptomatic individuals who are older or who have comorbid conditions. And finally, like I said, if you have enough tests, you should test everybody that presents with a symptom that you cannot explain by any other cause, and it's a symptom that could be attributed to COVID-19. So regarding testing, already some things were mentioned, so I'm not going to spend too much time. So PCR is what we use, and there's different platforms and machines to do this. Nasopharyngeal swabs are preferred. They appear to have more sensitivity. The sensitivity overall, this is a kind of a concerning area. It's reported between 75 and it's actually 85%, that's a typo. But we don't really have good data on individual tests because they've gotten very fast track clearance by FDA. So they were not very strict in requiring this information. And I am not sure what gold standard they're using to compare these tests to. But anyways, that's what we have and that's the best we can do. In our situation, we do 2 tests to exclude COVID from a patient that we hospitalize, because we want to make sure we don't get someone out of airborne isolation if they could have COVID. Serology has been FDA approved. I think it will be very useful when we know what the positive and negative predictive values are to know if someone is immune to the disease or not. Until that information is available, I think it's just a research tool, although there's a lot of promotion on serology. I have not read a paper that gives me clear guidance on what it really means and how sensitive the test is. And there are some reports that 6% of the individuals with some of these kids who have had COVID positive tests do not have a serological response. So PPE, I'm sure you're well versed on it, so I won't spend too much time. But you do need gowns, you do need non-sterile gloves, you need a mask. An N95 is required if aerosols are being produced, and also is recommended if you have enough N95s. But if you don't, a surgical mask will do for situations in which aerosols are not being produced. And of course, eye protection, a face shield or goggles. Glasses will not cut it, your normal eyeglasses. So there have been other recommendations from CDC, and you've probably heard them in the CDC recommendations, or read them, or you heard them in the news. So masks for the community. This is just a measure to decrease those asymptomatic individuals who may be spreading the virus, to decrease that spread. The masks are the homemade masks. They're not designed to protect you from getting the infection, but it's to protect others to protect people from those who are asymptomatically shedding the virus, or maybe symptomatically shedding the virus. The CDC came with a recommendation recently in which surgical masks are recommended for all patients. Okay, so let me clarify here. On this slide, I made it for Cherokee Nation because this is our guideline. But the CDC recommends that all healthcare workers use a surgical mask if they're inside a healthcare facility at all times. Visitors are allowed to use cloth masks, but if you have a surplus of surgical masks, you're also allowed to give the visitors a surgical mask. But it's not really a requirement for visitors. It's only for healthcare personnel. Briefly, due to the lack of N95s, or there's been many ways to extend their use or reutilize them. And recently, there's been 2 publications of using ultraviolet light. And the Nebraska, I put the website there if you want to reach it. It has all the process, very detailed, describe on how to do it. And the FDA granted certain sterilizers that use vaporized hydrogen peroxide gas approval to use that. And the important thing is that many hospitals have these machines. I did not even know that. We have one in our system, and they're looking into getting it ready to use it. And the beauty is that you could recycle an N95 10 times. So it basically increases your N95 stock by 10-fold. So for people who have to intubate, hospitalists, anesthesiologists, there's a really cool video in New England Journal of Medicine that you put this plastic box on top of the patient's head, and you can get your hands inside through those little 2 holes, and you can intubate a patient, avoiding splashes and contamination of the environment. This does need training, though. You cannot do it the first time you're going to intubate someone. But I think it's interesting for those who want to take a look at it. And the video's online, and it's free. So this is a question that comes up very frequently. When do you stop isolation measures on someone who is COVID-19 positive? So the CDC came out with guidance, and it's divided in individuals with symptoms and individuals that are COVID positive but asymptomatic for whatever reason they got tested. So when the patient has symptoms, there's 2 strategies: a non-test-based strategy and a test-based strategy. The non-test-based strategy, I think it was basically done because we don't have enough tests. But the bottom line is that 3 days after the patient has recovered from their symptoms, and at least 7 days after the symptoms have started, you can get them off isolation. And the test-based strategy requires testing on 2 consecutive days. So after the patient's asymptomatic, you do a test, COVID test one day, COVID test the next day. If both are negative, they can go back to their usual chores. For health employees, we are using test-based strategy. For non-health employees, we're not. And the only other situations that we use test-based strategies, because CDC also recommends it, are in patients who are discharged from the hospital, returning to nursing homes, or immune compromised. And the rationale for this is because it seems that patients who are sicker have higher viral loads and can have the virus detected for more prolonged periods of time. Individuals who got tested asymptomatically and are positive, they should be kept in isolation for 7 days only, and then they can return to their usual work. Now, if you're a healthcare provider and you got COVID-19 and you met the previous criteria, but there still are some more strict recommendations. So if you're going to do patient care activities, you have to wear a mask until you hit day 14 after your symptoms started, or you should not be seeing immune compromised patients for at least 14 days, and you have to self-monitor during the period that you're back at work until you hit those 14 days. So planning at the clinic level, what we did in our facility, just following recommendations, we limited the number of entrances. We triaged patients to a dedicated team who sees respiratory infections. We call it the screening clinic. It was originally called the COVID clinic, but we wanted to avoid stigmatizing, so we call it the screening clinic. We have a dedicated team tracking patients and results, and we sent all the healthcare workers we could home to work from home, and especially those who had risk factors of getting a severe disease. And we really fastly switched to telemedicine, and we're doing like most of our clinical consultations through telemedicine. At the community level, this was covered already very well by the EPI group today, but it's basically social isolation testing and contact tracing. What I do want to mention is that let's not forget about essential services, especially in vulnerable populations like the elderly, homeless, and people who inject drugs. Many elderly people live by themselves. We're asking them to stay home. If they don't have family members, we need to make sure someone checks on them periodically and make sure they have food and their medications and all their necessities. So treatment, I'll cover it fast because the bottom line is we don't have any effective treatment. So I'll just mention real quickly that there are trials using ACE inhibitors and basically ARBs, and I'll cover that briefly. There's one antiviral by Gilead that's undergoing randomized clinical trials. We do not have results yet. They have reported the results on a compassionate use study, which was not randomized, of course. And the results seem promising, but the bottom line is that we have to wait for the RCTs to be available to see if this drug is useful or not. Lopinavir, ritonavir, and a drug we use for HIV, there was one published trial in which it did not work. There's a lot of reports on hydroxychloroquine, but the bottom line is that we do not have any randomized controlled trial that tells us that this drug works. There are several ongoing, and hopefully we'll have some information soon. But we do have information that there's toxicity to this drug, so we need to be careful with hydroxychloroquine. There are studies using IL-6 receptor blockers, and I don't have any results to give you. Steroids should not be used only in clinical trials when you're evaluating their effect in ARDS. And there's a lot of studies going on convalescent donors for plasma and for hyperimmunoglobulin, but we don't have any results, yes, except anecdotal reports of 5 cases here, 10 cases there that apparently did better, but they were not controlled, so we don't know. Really quick about ACE inhibitors. So ACE inhibitors and ARBs prevent the production of formation of angiotensin II, which is a potent vasoconstrictor, which has physiological roles, but it also has deleterious roles when it interferes with the epithelial lining in the alveoli in the lung. And very interestingly, there's an ACE2 receptor which modulates the level of angiotensin II that we normally have. This receptor is the receptor that binds the coronavirus. So it's very amazing that why would the virus choose this receptor? I guess it's evolution. So initially there were concerns that if you were taking ARBs or ACE inhibitors, you may have more ACE2 receptors, and that could put you in a bad spot to have more susceptible for infections with coronavirus. But the bottom line is that we don't know. There's no human data. So due to the fact that a lot of people need these medications to maintain themselves healthily, the Cardiology Association recommended not to stop any ACE inhibitors or ARBs on your patients. And until further data is available, that's what you should be doing. There are 2 studies, one using ARBs to see if it helps, because some people think not only that it's not deleterious, but it could help, because if you have high ACE2 levels, it'll block angiotensin II and prevent the lung damage caused by the virus. This is just to show you there's been reports of severe toxicity to hydroxychloroquine, basically QT prolongation, and that's why we should not be using this drug, especially the combination with azithromycin routinely. And the Infectious Disease Society of America just came out with guidelines that are very interesting. And then, I mean, these are guidelines, and it's for you to look and see if they apply to you. And I think, but they're very good and conservative. So everything that's in green means that you could use this combination or the drug they're proposing outside of a clinical trial, but you would have to make a registry and collect the data and be able to report that data at some point. Everything that's in red means only in the context of the clinical trial. So the combination of hydroxychloroquine plus azithromycin should only be used in the context of the clinical trial. Hydroxychloroquine alone could be used outside of this context if need be. And the same applies for Kaletra and for steroids. And well, steroids should not be used at all except in the clinical trial when the patient has ARDS. So I would encourage you to review these guidelines, and they're pretty thorough and very well done. So finally, everybody has seen this slide, either in your medical journals or in Fox News or in CNN, whatever you prefer. The bottom line is to reduce the number of infections in the unit of time is important, because that way we maintain our health capacity to take care of patients who get very sick. And that's basically the concept of flattening the curve. It's not that we're going to eliminate infections, we're just going to prolong them in time. And there might be some effect in decreasing the total number, but the important is just to prolong them in time so we have capacity to take care of the patients. Following the isolation at work and at home rules are very important. Contact isolation is critical and will be, contact tracing is critical and will be a fundamental stone in the evolution of this pandemic for us to be able to control it. So I praise the work that you guys are doing. And there's no proven treatment available so far, and I don't think there will be for a while. I didn't talk about vaccines first. I don't know anything about vaccines. And second, because we're very far away from vaccines. And we need to adapt and adopt as soon as we can, because everything changes on a daily basis, and we just need to keep informed with all the medical information that's coming out there. So I'll stop here. And I have a few minutes. I am sorry, I have to leave like in 2 minutes because I did not know, it's my fault, that the meeting was until 12:30 and I have a meeting at 12.
We have a couple questions from the chat. With PCR testing, what does it mean if the test comes back as positive for pan-SARS coronavirus, but negative for SARS-CoV-2?
Well, that basically means that the patient has a coronavirus, but it's not COVID-2, because the multiplex PCR that we use detects all the other 4 coronaviruses. And actually that same platform will have the COVID-2 included soon on the same test, but I don't think it's there yet, or at least we don't have it. Maybe it's some other places have it. But you just have another viral infection, not the COVID-2, which it's much less severe than COVID-2.
And another question, with the variation in cases being asymptomatic, how should healthcare facilities decide if or when to test direct care staff that are treating COVID-19 positive patients?
Well, I'll let the EPI group answer that if they want to. I have my opinions on it, but I'm not an epidemiologist. Well, I can give my opinion first because I have to leave in like in 2 minutes. So I think it's a matter of having enough tests. If we had unlimited amount of testing, I think the rational thing to do would be to test everybody. And everybody who's positive should be in isolation until they don't infect anybody within those 14 days using the CDC guidelines. The problem is that we don't have enough tests, and we have to restrict it to those situations in which we need. But if we had enough, I think I would test anybody who walks in a healthcare facility, or anybody who when they resume flights, anybody who jumps in a plane, anybody that goes into a place where there's a lot of people should be tested. But I think it's just a matter of not having enough tests.
This is Christy Duke, and we actually struggled with this question quite a bit about community screening specifically with the Abbott test. I think our big concern is somebody who's showing symptoms but tests negative. There needs to be probably a massive community health campaign that a negative may not be a negative, and that is not licensed to go running around all over the place. I think that there needs to be a whole lot of awareness for that. But certainly I think in a healthcare facility, a negative may not mean that you're negative, but a positive, an asymptomatic positive healthcare provider should, be isolated as soon as possible. So I don't know if there's any specific guidance for that, other than the fact that the concern is that you've got an asymptomatic provider spreading it around to potential patients.
Well, no, that's a great point. I think that the fact that now we have to use surgical masks inside the healthcare facility, that will decrease the amount of shedding of those asymptomatic providers. So that will definitely help. And we just need to be very compliant with those recommendations. And also I tell my nurses, stay 6 feet apart unless you need to mingle for whatever reason. But if you have to, do it for less than 10 minutes and use your mask, etc. So that's going to help. And you're right. I mean, we have a lot of false negative rates. We don't know exactly how much with each test. It will vary. And in hospitalized patients, we're using 2 tests before we get them out of airborne isolation, just to be careful. But no, I agree. And there's a lot of unknowns. And sometimes we just do the best we can and use our best judgment for that situation. And hopefully with time, we'll have more data and be able to implement more interventions with some evidence-based guidance. But right now we're kind of in the clouds in some areas.
And that's been our debate. You know, what does a test tell us? And that's what we're answering. A positive tells us that there's a positive, and that's good information to have. So what is it that we are going to do differently from a public health approach based on the results of these tests? And that's really the underlying question there.
Yeah. Right. Okay, I have to jump out. I'm sorry. And thank you very much for your attention.
Thank you, Dr. Mira.
Thanks so much, Dr. Mira.
Does anybody else have any questions? If you want to take yourself off mute and ask your question. Or if you're on the phone, press *6 and ask.
I don't know if any of your tribes would be interested, but we were on our leadership call yesterday afternoon, and one of the tribes is actually using the Abbott tests, and because of that lower sensitivity and specificity, they're doing like a little trial of their own and keeping data on it, but doing 2 tests, 2 of the Abbott tests, but 2 tests to see if it shows anything for their community. And I don't know like how many they're going to do, but that was something that they were wanting to do.
Okay.
Thank you. I do think that would be of interest to some of our tribes. We are still hearing on the ground about the lack of good testing supplies and materials available. So that is certainly a consideration, although in the past week that does appear to be changing. So thank you for that.
Yeah, and I think it's only, I mean, knock on wood, I mean, it can only get better as far as how many tests are out and available. But yeah, they were going to use their first batch of the tests from IHS actually to do that, to share a little bit more information. But definitely, probably for a time when availability is increased.
Yeah, the other thing that could be done is to send off a PCR test simultaneously with the Abbott test and then compare the results. And, you know, that will give us, I think, some idea about the true sensitivity of this test. Yeah, I'm not nearly as concerned. Looking at the data that the company sent out, I'm not as concerned that there are going to be false positives. I think the technology is such that false positives will be very, very low. We just don't know what the false negative rate's going to be. I don't think from looking at the data that the company sent out that the test is quite as sensitive as PCR. Now, I'll say a bit of a caveat to that is the reason that the sensitivity with PCR is, as you know, not as good as we would hope. I think the problem comes often with transport. You know, these tests are being held up for sometimes more than a week, and the sample degrades if it's not kept very, very cold. In fact, after 72 hours, it's supposed to be kept at -70 centigrade. That is really, really chilly. And I think it's hard to maintain that kind of temperature. So the advantage of the Abbott test is, you know, you get the sample, you do the test right then and there. And so there's not that transport problem that you have with PCR testing. But, you know, we just, at this point, we just don't know how sensitive a test it actually is.
There's another question in the chat from Carrie Janis. She says, here at Mohegan, we do have the Abbott, but as you know, we are PRC only. Can the surveillance tool and RedCap be used by us as well?
I'll take that. Hi, Carrie. This is Tori with USET. Yes, the surveillance tool is designed to capture results from all COVID-19 tests. The information can be entered even before you get the results, just to put in as the person under investigation. And then once you get those confirmed results, you can go in and update that case to a lab confirmed case or a probable case or not a case. And if you do want to have a conversation offline, we can have that call as well. Yes.
Thank you, Tori. Just a reminder, in the chat, there is a SurveyMonkey link. Please copy and paste it into your browser and take the survey. It's 3 questions, very short, and it'll help us out a lot. Anybody else have any other questions?
For those on the phone who would like the information we presented here, you can go ahead and email me, Lauren Burns, at lburns@uset.org. If you would like any of this information, we're not sure who you are, but yeah.
Great.
Awesome. Emily, do you have anything?
No, I was just gonna say, also, if you're on the phone, you could unmute yourself right now and tell us what your email is too. And we could send that over to you if that would be easier. But yeah, I'm sorry that the link isn't active or highlighted in blue. I don't know what's happening. So you just have to copy and paste it.
And we are planning to host these calls every Friday for the time being, as it's needed. So if y'all have any questions or want something discussed next Friday, we are more than happy to take those and help with that in that sense. Yeah, Brian, Emily, anything else?
I don't have anything.
Great.
Are there any other questions?
Well, thank you so much for everyone who has attended. We really appreciate it and hope this has served you in some sense. And I can provide our Epi Team's contact if you would like that in an email as well. So thank you, everyone. Have a good Friday.
I got the chat.
Okay. And I stopped.